What is the PaO2 by FiO2 ratio in this case? Normal PaO2 by FiO2 ratio is normal PaO2 100, FiO2 0.2, 100 by 0.2, 500. That is the normal PaO2 by FiO2 ratio, P by F ratio. Here what is the ratio? PaO2 is 80. Okay. PaO2 is 80. FiO2, we take it as 0.4. 80 by 0.4 how much? So PF ratio, what happened to PF ratio? 200. So normal PF ratio is 500. Okay. PaO2 100 and 0.21 FiO2. So 100 by 0.2, 500 is the normal PF ratio. Here it is 200. Okay. Means that indicates patient has significant respiratory failure, acute lung injury. So if it is less than 200, it means there will be almost shunt fraction of more than 20%. Intrapulmonary shunt fraction, it will be more than 20% if PF ratio is less than 200. Okay. Then what is the gradient in this case? Alveolar arterial oxygen gradient. So look for alveolar arterial oxygen gradient. So what is the formula here? For that we should know alveolar oxygen, PaO2, B capital A. Capital A indicates alveolar, small a indicates arterial. We know PaO2, small a PaO2, that is 80 millimeters of mercury. But we should know alveolar oxygen pressure, P capital A O2. The formula is FiO2 into P atmosphere minus P hydrostatic pressure minus PCO2 by respiratory quotient. The formula for gradient. Here FiO2 is, let us say 4.4 into atmosphere will be 760, hydrostatic pressure will be 47. 760 minus 47, that is standard, around 710. 0.4 into 710 minus, what is the PCO2 here? 24 by 0.8. Normal gradient is 0 to 10. Normally there won't be much gradient between alveolar oxygen and arterial oxygen. In this case there is significant gradient. Okay. High PaO2 gradient. Okay. What does it indicate? In the case of hypoxemia, first we should check for gradient, alveolar arterial gradient. If alveolar arterial gradient is normal in a case of hypoxemia, if PaO2 is low and if gradient is normal, the causes are central hypoventilation. Gradient is normal, causes are central hypoventilation or neuromuscular weakness. These two are the important causes. If gradient is normal, in all other causes, gradient will be abnormal. Okay. So how to differentiate those two? Central hypoventilation and neuromuscular weakness. We should check maximum inspiratory pressure efficiency. Muzzle efficiency we should check. That is called NIF, negative inspiratory force. The formulas for maximum inspiratory efficiency. We should check for maximum inspiratory efficiency, muzzle efficiency, maximum expiratory efficiency. If inspiratory muzzle efficiency is weak, that indicates neuromuscular cause. If inspiratory muzzle pressure is normal, then the cause is hypoventilation, central hypoventilation. That is if gradient is normal. If gradient is abnormal, if gradient is high, so two important causes are shunt, intrapulmonary shunt, VQ mismatch. In this case gradient is high. So in this case PF ratio is high, that indicates respiratory failure, acute lung injury. So in this case gradient is high. So two important causes are shunt and VQ mismatch. it is correctable with oxygen, if PaO2 increases with oxygen, that is VQ mismatch. If it is not correctable with oxygen, that means shunt. That can be intracardiac shunt or intrapulmonary shunt. Or if V by Q is 0, that means almost behaves like shunt. V by Q is 0 means ventilation is 0. There is alveolar collapse. There is left lower lobe complete collapse of the alveoli. Alveolar collapse or alveolar edema. Even though there is ventilation in the airways, alveoli are completely collapsed. Means ventilation is 0, but perfusion is normal. So V by Q is 0. V by Q is 0 means it behaves like a shunt. There is no ventilation, 0 ventilation to those alveoli. Okay. So if it is correctable with oxygen means VQ mismatch. If it is not correctable with oxygen means we should look for shunts, intracardiac and important intrapulmonary shunts. So in the VQ mismatch again, there can be VQ mismatch means all pulmonary causes, parenchymal causes, diffusion causes, all they come under VQ mismatch, ventilation perfusion mismatch causes. Or there can be DO2 by VO2 imbalance. DO2 means delivery of oxygen into the tissues. So if cardiac output is low, delivery of oxygen will be low. VO2 means oxygen uptake by the tissues. Ultimately, what is important? Tissue oxygenation. Respiratory failure means there are three components. One is ventilator failure, ventilation failure. Two is oxygenation failure in the alveolar capillaries. And most important is third one, tissue oxygenation. That again it comes under respiratory failure only. Cellular respiration. That's an important factor in sepsis and various critical care problems. Most important component is tissue oxygenation. So for that we should know DO2 and VO2. So delivery of oxygen into the tissues and uptake of oxygen by the tissues. So what is the formula for DO2? The DO2 depends on cardiac output. Delivery of oxygen depends on cardiac output. Here case of severe LV dysfunction and low cardiac output. So delivery of oxygen will be low. So normal uptake of oxygen tissues is around, it will be around 25%, but if the component part is lower, even VO2 will be low in extreme cases. So we should look for DO2, VO2 imbalance. One simple way is check PVO2, venous oxygen pressure. PaO2 is 100, arterial oxygen pressure is 100, PVO2 is 40, venous oxygen pressure. Arterial pressure is, PaO2 is 100, venous pressure is PVO2. PVO2 will be 40 millimeters of mercury, PVO2. So if PVO2 is very low, less than 40, that indicates DO2, VO2 balance. PVO2 we can easily check venous oxygen. We can keep a central venous catheter. The central venous oxygen saturation. Oxygen saturation represents venous oxygen saturation, mixed venous oxygen saturation. Indirectly we can get that assessment. EBG analysis, venous blood gas, we can get PVO2. Okay. If PVO2 is less than 40 means there is DO2, we should look for DO2, VO2 imbalance.